So, without wasting time, I think I'll start off. So, while cracking the posterior plate, we have all seen, in India we don't have dearth of this hard cataract. So, we all see grade 4, grade 5 cataracts, and we tend to do phaco because we need to do phaco on that. So, there is a particular technique for this, and why it is not cracking? We are not doing it right. That is the first thing I need to tell. So, if I do it right, if it is not happening, then we need to change the technique. So, ideally, I would want a pupil to be dilated very well. So, this is a really hard cataract. So, I will stain the capsule with the trypan blue so that I can see the edges of the capsule margin. That's very, very crucial, because while we are chopping, we may hit on the capsular margin later on. You will lose track of the rexes, and slightly larger than regular, because these capsules are stiffer than what we think, and the whole bag is stiffer than we think. And then these lenses need to be split very much, and that is why we need to have a rexis bigger so that you don't exert too much of pressure on the bag. So now I take off the epinucleus part a little bit and then go into the center and widen it a little and go deep. So this is where I'll go into the center, and this chopper is 2 millimeters long. Not very scary. Don't be scared about long choppers. Nothing is going to happen. So I am splitting in the periphery and coming to the center, and once I do a 2 or 3, I get a gap there. So once this gap is there, see the depth into which the nucleus is being buried into, and when the nucleus is being separated, it may lose hold. Then go further into the nucleus and make sure it is held very well. That is the first thing. Second thing is to use the sharp chopper very efficiently to go into the depth of the chop which we have created. So a chop may be incomplete, but then we need to go further into the depth of that chop with the needle, with the chopper tip, and then separate further. That is how you can separate in steps, so that you don't have to separate very widely. And then you can identify the posterior plates, the lamellae which are not separated, while the hold is very strong, and individual lamellae can be separated. So this is the crucial 2-3 points which we need to make sure that you are doing. While this is happening, the pupil should not become small. If the pupil, most of these cataracts come with smaller pupils, they don't dilate very well, or they tend to constrict off very fast during the procedure. You take more time, there may be irrigation, there may be fluttering of the iris, all that can bring down the pupil. If the pupil comes below the rexis size, I will stop and put in iris hooks or a ring and see properly while you are chopping. That is one most crucial. So this we have tried and it has not happened. Though then we need a plan B. So in plan B, it should work. So my plan B, it almost 100% time works. So how does it work? So in a hard cataract, so I go to the depth so that I can see the red glow there. So I try to crack, but still if it doesn't crack, you focus on the periphery of the lens. So I hold the nucleus, the periphery chops. So I don't insist on the central chop at all. So go to the periphery and in the rexis area itself, but make sure the periphery cracks. So peripheral full thickness cracks are made. That happens very easily. The posterior plate is thicker and more leathery towards the center, not in the periphery. So this happens, and keep on doing it all around. And it depends on the size of your tip. This is a micro tip. We can use larger tips that holds much better, but then the chamber will not be that very stable as we want it to be. So according to your machine, how much it can hold, have vacuum. You don't have to have 500, 600 vacuum in all cases. You can have 300, 350 and easily hold well and chop. And now it has been chopped. Now see what happens. It is held and brought towards the center. And there it is partly loose, and I am eating it off at the rexis margin. Eating it off from the neck. So the peripheral part which was there in the bag gets eaten off. You can get the assistance of the chopper, or you don't have to. You can just eat through, but don't do it in the equator, close to the equator. Move it towards the center within the rexis margin, and then eat it off. And if it is larger, you can subdivide it, make it into further smaller pieces, and then 360 degree this will happen. And once that happens, you will end up with a thin disc with an intact posterior plate. That doesn't matter. Once you hold it or use your second instrument to tap it up, it comes up and it is free. And very important to use sodium, the viscoat, or you can use the Indian company's dispersive viscoelastic on and off. So this mostly works, almost always works. But the pupil, again, I am telling you, in this case also, pupil should not become smaller than your rhexis margin. So if it becomes smaller, always use iris hooks. So this is one case where this is a high myope. And they tend to have very large, very hard nuclei, and they have calcifications. If you have noticed, they can have calcifications, and rhexis is a mandatory thing. So if you lose rhexis, all this is gone. You cannot do all this. So don't run into these calcifications. And then now when I'm chopping, when I'm closing towards the center, see that white thing which is down below there. So if you think that there is a PC rent, the good thing about this technique is that the whole nucleus is retained connected till the end. So if it is there like that, it usually does not drop through a small opening or a small piece rent. So if you have multiple small pieces, you tend to drop off these pieces. So this is another good thing to do when you suspect that the PC is open. Sometimes there may be calcific plaques there, sometimes it may be open. So you don't know, So I am taking this nucleus out of the bag, and then the separation happens in the supracapsular area here now. So this is to reduce the split or the separation forces in the capsular bag if you have a weak capsule or an open capsule. Still, the center I am not split, but the peripheral chopping is happening. So this technique has won a Best Video Award in the ACRS in the early 2000s, I remember. But still this holds good for our kind of very hard cataracts which we have. Now I have finished half of the nucleus and I see this white plaque there. But then I press on it, I can see that there is capsule there. So it is not a piece rent, so I am very confident now push the nucleus back into the bag. But still I can even complete the chop here because it is not so very hard. See, I hold it, and because there is space in the bag now, it can be separated widely. But while separating, don't insist on one full separation in one stroke. Partly it has separated, stop there, go in further with the chopper and separate less, little by little, so that you don't have to stretch widely. So that is one crucial point which we need to remember, and all these cases you can complete very successfully if we follow these two. One is to follow the ideal steps of posterior plate cracking. Second is to do the peripheral chop and do the posterior disc at the end. And use of viscoat during surgery, please insist. Endothelium is anyway costlier than viscoat. So please use one or two and charge the patient also. If they're coming so late, means they have to be charged. Your technique is good, but then they have to pay more for protection of their own endothelium. Thank you very much.
Thank you, Dr.